So we're going to have a panel now after those two very wonderful introductory talks. Thank you very much. The panel is entitled Newborn Genetic Testing or Genetic Screening as a Gateway to Lifelong Personalized Medicine. My name is Paul Billings. I'm an internist and medical geneticist. I'm an adjunct professor at Stanford University in the United States and have been practicing medical genetics for a long time. I'm going to just make a couple of introductory remarks and then introduce the panel. Some of the panel are in the room, some of the panel are remote, and we'll field some questions. There may be some questions left over from the excellent talks that we just heard. We can field those at the end of the panel as well. So a little over 45 years ago, Dr. Cyprus and I took the Hippocratic Oath. And at that time, we swore to do no harm and, when possible, to relieve suffering. Systems and practices have developed over the centuries in response to this oath to approach symptomatic and acute care. Remarkable progress, particularly in the 19th and 20th centuries in surgical practice and in infectious disease care, have both set paradigms and cornerstones for acute care healthcare system development. In parallel, and most recently, and we've heard a little bit about it already, investment in public health has grown, reducing toxin exposures in early childhood, understanding the impact of radiation exposure and nuclear warfare as a public health issue has been elucidated in populations. And finally, implementing systems for identification and diagnosis of metabolic genetic disorders like phenylketonuria, as well as cystic fibrosis and heme disorders like thalassemia and sickle cell disease have become available, and some are amenable to treatment and to later complication avoidance. The menu of proven successes has been limited, in my opinion, and we've heard that already echoed. But there is promise for a more precise and effective practice of medicine, not so grounded in symptoms and not so subject to the diverse opinions of experts who often don't agree with each other. This panel will explore the evolution of this kind of precision medicine and the impact of more therapies that may work that are on the horizon and how they may change the practice of precision medicine. Now, let me introduce my distinguished panel members. And I wish they were part of my family, actually. Some of them are very close to being part of my family. First, remotely, Dr. David Bick is the principal clinician in the Newborn Genomes program at Genomics England. Dr. Bick got his MD from George Washington University, trained at Yale University, and was for many years a professor at the Medical College of Wisconsin. The second speaker will be Dr. Martin Reese, to my right here. Dr. Reese is the president of Fabric Genomics, which is a subsidiary of GeneDx. He has been a pioneer in the use of software to interpret genomic data with previous enormous successes with the companies Neomorphic and ID by DNA. Dr. Reese has his PhD from the University of California, go Bears, and the University of Hohenheim. And if I mispronounce both German and Greek names, you will forgive me. And he has a master's degree from Heidelberg. The third speaker will be Dr. Ali Gharavi. He will be remote. He's the Hatch Professor of Medicine and Chair of the Department of Medicine and Physician-in-Chief at New York Presbyterian Hospital, which is the flagship of Columbia University in New York. Dr. Gharavi Also got his MD at George Washington University. He trained at Mount Sinai in New York and Yale. He's an expert in genetics of kidney diseases, both in kids and in adults, and is really a visionary in personalized medicine. Two of the speakers who are also here and local have joined the panel. The fourth speaker will be Manolis Papasavvas, and if I mispronounced his name, there needs to be more people named Smith in Greece, as far as I'm concerned, and more universities that are called Cal. In any event, Manolis is the president of the Children's Oncology Hospital, and I'll botch this name too, Vardanominas. And again, I apologize. He has a master's in hospital management from the University of Leeds and has 25 years of senior experience managing healthcare organizations both in Greece and abroad. And then our last speaker will be Dr. Kyriakos Souliotis, professor of healthcare policy and dean of the School of Social and Public Policy, University of Peloponnese. He's the director of the Lab of Evaluating Health Policy, Technology, and Behavior. He has a PhD in health policy from Pantheon University here in Athens, and is a distinguished health economist. So with that as background, let me then pose the first question to our remote speaker, Dr. Bick. What are the data findings so far from the UK program, the Generations Study, and what are you expecting to see over time, including some of the barriers that might not have been expected, but which you are noticing?
Right, so I'm hoping everyone can hear me okay. Yes, good, excellent. So just a few words. I'm a clinical geneticist from the United States, and I practiced in the States for about 35 years, as noted, and also ran whole genome sequencing clinical labs in the States for 10 or 15 years. So about 4 years ago, I joined the Generations Study, which is a study to sequence 100,000 newborns to look for treatable conditions. So I thought I'd say a few words about the program. And also, I do want to emphasize how much I appreciate being invited to this panel, because there's a great deal that we can do today through newborn genome screening, I believe, and over an individual's lifespan. So let me just give a few words about where we are with the program. We have recruited about 44,000 families to the program so far. We've sequenced about 20,000 genomes, because remember, many of these women are still pregnant. And we have found about 120 positive cases. Of those, we've had 11 that were false positives, but all the others so far seem to be true positives. So what did we go about looking for? We were looking for highly penetrant, early onset treatable conditions. And if you go to the Genomics England website, you'll see we had 4 principles for deciding which conditions to include in the program. And those principles are fundamentally that the gene is well understood, that the condition is highly penetrant, that the condition, we expect that children will have significantly improved outcome, and that we want to look for those treatments that need to be started in the first 5 years of life, and that the condition has to be one which is already part of the National Health Service, one where anyone in the country could have access to care. And so that's sort of where we are with the program so far. And so other questions may come up about the particular conditions. I would say the things that we feel were critical to the success of the program, the first is engagement with the public. And it probably won't do any good to try and put something in the chat. If you go to the website, there is a document which looks at the public engagement that we carried out in 2021. And from that, we use that as the jumping off point for the program. We have extensive connection with and governance by the National Health Service through NHS England. And we consider that to be incredibly important for that external governance. In terms of barriers, if you will, I would say that education is the greatest barrier, both to educate the public at large, but also to be clear with the physicians themselves what are the conditions we're looking for, why we've included some, why we've not included others, and just the general issue of when you find a result, so let's say it was spinal muscular atrophy, making sure that your processes for getting that information from the sequencer to the analysis pipeline to be reviewed by a clinical scientist and on to a clinician who will immediately take action, that pipeline is incredibly important and is one that we work on all the time. So that's really about the program. Just a word about the future. As I pointed out, we're really focused on finding individuals whose treatment needs to be started in the first 5 years of life. But we're now looking at the question of once the program ends, and we anticipate finishing recruitment in November of this year, maybe early next year, the question would be two things. Obviously, there is the analysis of the program, and I can have a lot of discussion about that if people wish. But also this future-looking question, would we want to invite families to a further research where we would start to look for conditions that have onset up to age 20? There's also at Genomics England underway an effort to start an adult pharmacogenetics program. So there are a number of ways in which the genome could be used across the lifespan, and that's sort of one of the directions I believe that England is taking. And issues that we could discuss on this panel are issues of data storage, security, what happens when patients change their location, they move around the country, they change providers, what about periodic reanalysis, what about new technologies like long-read sequencing, and maybe even the most basic, which is which conditions should you look for, which I believe will turn out to be very country specific. So I will end there.
Thank you, David. I actually have a follow-up question for you. It occurs to me early on in biochemical screening in the United States that there was a small fraction of parents who declined to consent to biochemical screening. I wonder if you'd seen any of that in the project in England.
We're starting to try and we're doing our best to evaluate people who agree to the program, people who don't agree to the program, and why the people declined. Many of the declines are simply people don't want to take part in research. And so that's going to be an issue that you really can't resolve in a research program. We're also very, very sensitive to the notion that we want to include all ethnic backgrounds. So obviously most individuals in England are white British, but we have a substantial Pakistani community. We have a substantial Indian community. We have a substantial community from Africa that live in the UK. And so we've been acutely aware and very sensitive to being sure that we're including those individuals in the proportion that they are in the population. And I will say that that has been a struggle. And so that's something we work on almost every day, is to try and make those, have those individuals be included, because if this is going to make sense, and one thing I want to emphasize is that there is no mandate to do this long term. The question is, where's the research? Where's the evidence? And so that our job is to be collecting that evidence. And so we need to have that evidence also from the minority community.
And we should hope that there's funding for your research as well going forward. Thank you, David. I'm going to now turn to Dr. Reese and ask Dr. Reese, What technical and data improvements have occurred in next generation and whole genome sequencing, and what will evolve over the next 5 years that will allow better and hopefully cheaper genomic newborn screening?
Yeah. Hello, everyone. My name is Martin Reese, and I'm coming from California all the way to you. First of all, thank you to the First Steps program, the Greek project, and Petros for inviting us here. And we have been partners in your phase 1. So we've helped you analyze your genomes in your first phase 1 study. So really excited about here. So I'm backing up a little bit. I'm trying to tell you a little bit about, David is talking about whole genome sequencing for newborn screening. That's really the leading project in this field. But how did we get here? So really what we can see in genomics, and my background has been 25 years in genomics, what made all this happen is really the cost of whole genome sequencing dropping in the last 5 years. So just to give you an idea, like 5 years ago, we would sequence a clinical genome for $5,000. So that was basically the norm. So you sequence a genome, you interpret it, you make it happen. And then what happened is that sequencing companies like Illumina, and we have, of course, Illumina here, really improved the technology and drove the cost of sequencing down. And that really has opened up like the whole field. And what's really important is before that, people were doing single panels, a few genes at a time. The problem with that is genes change all the time. We make new discoveries. We can't do anything. Once we have a whole genome sequenced, we have the blueprint, we have your entire genome. So we can actually add genes. Different programs want to add genes, remove genes. And so whole genomes really allows you to do that. And then, as David said, as these genomes are there, they can be reinterpreted. We can go back. We can go to families. We can do everything like that. That's a major shift from panel sequencing to whole genome sequencing. Just to give you an idea on cost, so 3 years ago, at the time, software and interpretation company, Fabric Genomics, we partnered with the Broad Institute from Harvard, MIT, and they were the largest sequencing center in the world. We partnered with them. We did interpretation at scale. The Broad Institute could do sequencing at scale, and we launched, and I just checked exactly 3 years ago, $1,000 clinical genome. So we brought the cost from 5,000 down to 1,000. The only way we could do that is really at scale, a massive sequencing center, and really a lot of IT-driven interpretation at scale. Manual work, every geneticist looking at every mutation, not possible. So that's really the shift that has occurred. Then what happened a lot is a lot of people have started to do whole genome sequencing first on sick people, mostly sick children. So Rady's Children's Hospital, Stephen Kingsmore, has started a NICU sequencing, really sick with symptoms, kids in the ICU. So there you could afford a $5,000 genome. So these efforts have been really progressed in the last year. David, of course, joined Genomics England. Genomics England sequenced 100,000 rare disease patients, not healthy people, but patients. So they have done that, 100,000 there. Stephen Kingsmore had sequenced 30,000. At Fabric Genomics, where we serve a lot of children's hospitals in the United States, we had sequenced 100,000 exomes and genomes. So we actually have a lot of patients with phenotypes, EMR records, and then the genome, and we could link these genes together. So that's really has driven. What has happened with that is databases where people deposit genes and rare diseases. The OMIM database 5 years ago were 3,000 genes. We heard today 7,000 genes, 10,000 conditions, all driven by these early efforts on rare diseases. Databases like ClinVar, ClinGen, they have ClinVar had like 1 million variants like 5 years ago, 3.5 million today. So these knowledge bases are growing because of all our efforts on sharing data and depositing data. And so it's really important to have that knowledge so that you can actually link these variants towards the patient. My company, Fabric Genomics, we just got acquired by the largest pediatric genomic testing company in the United States called GeneDx. Just to give you an idea, we have done like 1 million genomes now. So our database is called the Infinity Database. It's 1 million genomes of rare disease patients. So whenever we have a genome, we can search that database and we can say, have we seen that variant or that gene before? If so, what's the phenotype from the patient? So you can imagine it's a really great resource to identify novel variants, classify them, make sure are they pathogenic, are they not, are they penetrant or not. So all of this knowledge is really growing and is getting better and better. So that's what we have. We have massive data sets. We need to bring them together. And then Paul, you asked me what's the future going to be is everyone talks about AI now. So you can imagine if you have 7,000 rare genetic diseases, you have 3 billion variants in 3 billion genomes, 4 million variants. All these correlations together is perfect for AI. And there is no geneticist that can solve all these problems. So what we're doing today, we have models for each of these components to make a diagnosis. We have trained them before. We can retrain them now. So you will see that the diagnostic yield in sensitivity and specificity is even going to increase right now by all this data that's coming, by the AI that we're applying. And then the large language models really help us on the diagnostic purposes. So a lot of the knowledge is coming together. And so what you will see is you will see also big AI companies coming into the space. Just last week, Google came in. They published their first algorithm called the alpha genome. It's only for single nucleotide variants, but the predictability of the function of that is getting better and better. More data, AI systems make this better and make it accessible. Now at Fabric now we are putting all our data from GeneDx into our software so that you here at the First Step program, you can access all of this data and you can interpret your own genomes with all that data behind in the software platform that we can distribute, which is a really unique opportunity to take all this knowledge from the US and distribute it all around the world. So that tells you a little bit about what's coming. It's pretty exciting in our field right now.
It's very exciting. Martin, I've heard it said that some of the early submissions in ClinVar and some of these early databases were not top quality. Might have been spurious data, shall we say. I can imagine that might be a bit of a problem for the learning of these AI models and so forth and so on. What's your feeling about that?
Yeah, so that's a problem sometimes on these public resources that pretty much anyone can submit. So there's very little control what gets submitted and what's not gets submitted. So you can then find different errors that are submitted and things like that. Now, when we have multiple submissions, we can actually test whether they are concordant or non-concordant. And so usually when we have an update on our database, we check for all these concordances. And if we see that one submitter or one entry is wrong, we flag it to the clinician to reanalyze the data. And that clearly is a problem. But again, the more data we have, we can actually try to overcome all of these problems. So I would still encourage you to submit as much as you can to ClinVar. But that clearly we have to think about.
Well, it's very hopeful, and I hope you're right. Our next speaker is also remote. Dr. Gharavi, as I said, is a leader at Columbia University in New York. Ali, I'd like to ask you, how are you seeing, and you've cared for both kids and adults in your career, how are you seeing this transition from pediatric to adult care handled now? And what changes will all this genomic testing in the newborns foster in the next 5 years in that? Will it speed overall personalized medicine? Will this be a boon to personalized medicine or a boondoggle?
Thank you, Paul, for your question and inviting me. Thank you, Petros. My disclosure is I'm an adult nephrologist. I take care of adults with kidney diseases, but my research does span pediatric congenital disorders of the kidney. And the other disclosure is that I'm very envious that I'm not with you in beautiful Athens and in Greece. So I think this is going to have a huge impact on clinical medicine over the next decade and two. First of all, by identifying these kids who have these genetic disorders, we improve their care, we diagnose them. There are many targeted therapies that are available earlier on. I think that's the full rationale for doing this type of program. And so I think that's going to have a huge impact in clinical care in pediatrics. But the other thing is that as we take better care of them, of many of these genetic diseases, these patients live into adulthood. And so internists need to take care of them. Right now, there isn't a coordinated program for transitions of care for patients with these rare diseases. As we identify them, we need to do better transitions of cares and handoffs. And it's also important because the manifestations of some of these pediatric diseases evolve into adulthood. Many of these kids did not survive into adulthood, so we didn't know what would be some of the manifestations later on in life. And for example, for a disorder that I take care of quite a bit, which is renal cyst diabetes syndrome, or caused by CNV or a point mutation, the patients have kidney malformations that can be visualized on a prenatal ultrasound or very early on in life, but later on they can develop diabetes. There may be some neuropsychiatric manifestations, some cardiometabolic manifestations later in life. So it really helps sort of in terms of prediction of what might happen and managing their care a little earlier on. The patients with these genetic diseases, these rare diseases, also have differential outcome. And I think from the data from the UK, from the rare disease program, really shows that they may have a worse prognosis in terms of, for example, for kidney diseases, the patients with these rare genetic diseases progress faster to kidney failure compared to patients who have garden variety causes of kidney failure, kidney disease. And what's interesting about them also is that once they reach kidney failure and they're on dialysis or need a transplantation, they have a survival advantage compared to others who have chronic kidney disease who reach end-stage kidney disease. So I think that we need to understand the natural history better, and by recognizing them, we can stratify these patients and do the risk profiling a lot better. The other thing that happens, of course, is that for adult care, when we do the newborn screening, parents are involved, and if there's an inherited variant, then we can also screen family members and provide care for the parents. And so you benefit the health of the parent. As a result, the child, has parents who hopefully survive and are not affected or are not ill. And so it's good for the child as well. And as you know, many of these genetic diseases that we classify as being classic pediatric diseases, as we're sequencing more people, we identify them in adults. We're seeing this quite a bit. So it's just that we're at the ascertainment as it goes through sequencing now enables us to identify adults who have this, these conditions. So again, enables us to have better diagnosis and predictive testing. There's a lot of information in the genome for predictive testing as well. And so the data can be interpreted over time, as many of the other speakers pointed out. And so that's also great for risk stratification for patients and predictive care. I think by doing the newborn screening in terms of the education, by bringing this on earlier on, educating parents about the benefits of newborn screening, well, they themselves might be curious about and interested in getting genetic testing at some point in their lives. And so I think that would hopefully incorporate this into and give some education earlier on to we parents about the benefits and utility of genetic testing. And then finally, you're going to talk about it, but all these rare diseases cumulatively account for a large fraction of patients that are hospitalized and a lot of disproportionate amount of healthcare expenditure. And so we need to be aware of this so that we can hopefully manage this better and reduce healthcare expenditure as well as improving outcomes.
Ali, there are two, you make a very important point, I think. The right of the child to get a newborn test, which is now we're talking about doing whole genome newborn testing, may be the first gift that the child gives to the parents, because an identification, let's say, of a BRCA mutation or other kinds of mutations that might directly impact the parent might be done in the child, and then that information transferred to the parent. So that's obviously an enormously important public health outcome, really. But in the United States in particular, and I'm thinking primarily of cancer cohorts, the uptake of genetic testing has been, I think, slower than people thought it would be. That, the recommendations from the professional societies have been that people who've had cancer should have cancer-related panels, and then obviously that information might be transmitted to other family members as well. What do you think has been the reasons for the slow uptake?
Well, as everything, it's multifactorial. It's going to take a lot of time for clinicians who were trained decades ago to become familiar and feel comfortable with genetic testing. The guidelines help, I think, with this changing of the practice, but also I think we need to have wider availability of sequencing. It's available now, but in some points limited by reimbursement and the economics. And so if we have inexpensive testing available, and that makes it easier for clinicians to just order the tests, get the results back, and get some help with the interpretation, which is genetic counseling or expert genetic molecular genetics advice, then that thing will be accelerated. I think in nephrology, the availability of panel testing for diagnostics and making it very easy to access by multiple companies really made it, accelerated the uptake. And I think that's what we really need to do across all the different subspecialties.
Good. Well, I hope you're right, and I hope that we, certainly for those people who have symptomatic illness, that we may have a genetic variant that they don't know, that we get to a time when we're at full knowledge about that. So I think related to what Dr. Gharavi has just been talking about, Dr. Papasavvas, can you talk a little bit about the impact of all these disorders, both on pediatric as well as adult hospital care, and what new programs might be needed to make it work better?
Good afternoon to everyone. It is a great honor to be here, having served as a CEO of Greece's largest pediatric hospital. I have seen the front lines of child healthcare. Today, at the unique in Greece in public and private sector pediatric oncology hospital, we carry the noble legacy. Our mission is to provide the most innovative therapies in clinics, staffed with well-trained personnel and fully equipped with the most advanced medical equipment. In the last 5 years, we have performed 31 cellular therapies, including 6 therapies using our own CAR T cells. We have an independent institution in our hospital. It is the first one established in Greece, and we have the formal recognition of the Greek government. Our experience with genomic analysis is at the level of the study of genetic predisposition for childhood cancer. Our aim is to gain genetic information in order to be able to tailor the cancer treatment. In addition, we analyze genetically using NGS, next generation sequencing, the families of the affected child aiming and discovered other members of family having the same molecular alteration. It is a protocol that we have in the hospital, so every child that is admitted to the hospital and diagnosed with cancer, we do these NGS exams. And you think a little bit about the numbers. Every year in Greece, you have about 350 new cases of children with cancer, and 85% of these cases are coming to our hospital for hospitalization. And also have the unique bone marrow transplant unit in Greece, even in the public or private sector. In my opinion, the wider use of genetic analysis for newborn screening will be very useful. However, it remains to be proven. And also, the government has to find some funds to do all this program and to have a start level, to put to some, let's say, for the children with cancer or other diseases. They have to focus at the beginning and at the start to analyze. But on the other hand, we should be mentioned that there are undermined genomic alteration in terms of the clinical importance. Therefore, the knowledge of such alteration in the newborns might raise ethical issues and how the doctors will communicate it to the families.
Do you see that the barriers to, let's say, CAR T therapy, which is obviously a important project in your hospital system, that they're the same kinds of barriers, same kinds of funding, resistance, rare disease, as to this notion of newborn genetic screening?
Actually, Greece happens something strange. We are a small country, but we have free access to the health system. No matter how expensive is the therapy, all the people, even the refugees that they come to Greece, have access. We have children that come from Palestine and do bone marrow transplantation or CAR T cells, and they don't pay anything. Small country, but free access.
But what about approval? In other words, does the government, we have FDA and the Center for Medicaid and Medicare Services gets involved in the United States because they have to pay for these things.
Yeah.
So there's a lot of review of practices, even at elite hospitals like where Dr. Gharavi works, or the Mayo Clinic, or and so forth. When something new like CAR T cells comes and is beginning to be used, is there the same kind of government review?
We claim money from the central government, from the Ministry of Health.
Yes, and so and they do a very critical, or they want to see the data all the time and so forth and so on.
Yes.
I see.
Yes.
Well, good luck.
Thank you very much. Thank you.
Okay, then our last speaker, and then we'll open it up for questions and comments from the audience and amongst ourselves if there are some. Dr. Souliotis, you're an economist, and we forgive you for that. So what do you think about the historic impact of newborn screening?
May I share some slides?
You can show whatever you like, and how you would approach modeling universal genomic newborn screening programs. And he has, like a good economist, he has data, I assume, to show us here. Can you show his slides? Yeah, good. They were there a minute ago. Try again. No, I think maybe you need to hit your computer again. Let's see. Up, there you go. Oh, now they're gone again. Up, there you are. Oh. Is the connection loose? We're going to have seizures in the audience if this keeps up. Good. Oh. It wouldn't be a panel without a technical problem. It just doesn't. This is par for the course. Well, you may have to ad lib.
Let me add something what you said before with Manolis' presentation. In Greece,
Turn on your mic.
It's on.
There
Okay.
you go.
We have free access to every part of the system, but you asked about the regulation and the approval of such treatment, am I right? So
Yes.
we have a common strategy and we have a common approval through EMA. So if we have an EMA approval, it's almost automatically approved by the government. It's part of the system.
I see.
So it's easy. The problem is who's going to pay and how we're going to reimburse it and for what conditions. And this is the main question because we have limited budget, especially after the financial crisis hit this country 10 years ago. So we are now in a different situation. But now we're talking about GNS. If that was a manuscript, the keywords, I'm professor of health policy, so obviously I will add some keywords in this discussion. The main words are, of course, genomics, screening, lifelong precision medicine. But I would add willingness to pay or willingness to adopt or cost effectiveness and health policy priorities because I think that this is a critical issue for this discussion. I forgot to thank Petros for the invitation. I'm really very happy to be here with you. It's a great discussion. And in this discussion, there are some facts. Fact number one, the importance of screening is undeniable. We all know that screening is very important. And number two is that the practice of neonatal diagnostic testing is already established. So what's new? What's new is that we are moving now from the established neonatal diagnostic testing approach to a screening one. And this is critical because we're talking about both symptomatic and asymptomatic newborns for critical conditions, to my view. Research all over the world is now looking into hundreds of conditions, as we heard before, on the management of which GNS can have a meaningful impact, because we need to prove the impact and we need to prove cost effectiveness as well. As you can see, cost effectiveness evaluation is a critical part of the process. You see now at step 5, the program evaluation, we have a key question. What are appropriate outcome measures? What we will measure? Survival, reduction of morbidity, cost effectiveness, acceptability, adoption, what? We need to measure all, to my opinion. And that's why it's quite complicated. But before that, before cost effectiveness, I think that we heard this before, we have to measure and ensure endorsement of such a program by beneficiaries and the society as a whole. Because there are some concerns and barriers from the societal view of such a program. And this discussion is really very important in both scientific and policy discussion. And of course, there are tools for such analysis. We have an example here from Australia. The Baby Screen Plus study shows that the acceptance of the program is 99.5%, which is really high. And the parents of newborns enrolled in the study are willing to recommend to other families and friends. You can see the percentage is 93, which is really high. So there are paradigms of high acceptance of such a program. Of course, alongside this one, the endorsement, science and policy focuses on cost effectiveness of GNS, which is still undecided. It's not clear to me because we need more data. Until now, of course, we know that this cost effectiveness ratio depends on the specific conditions targeted and the screening strategy. For example, are we talking about a universal program or a targeted one? It's still under question. And until now, with the available data we have until now, to me, it seems that it will be highly effective in certain high risk and specific disease contexts, especially those for which treatment exists. And I think that this is the key point, if we would like to start a program like this in Greece. And you can see here some very good studies with a very accepted cost effectiveness ratio. You can see 4,000 per QALY or 2,000 per patient, and this is accepted even for a country like Greece. But there are also studies with a very high cost per life year. You can see in this one for hypertrophic cardiomyopathy, you can see the cost is 267,000. Okay, it cannot be accepted in a country like this. It's 6 or 7 times the per capita GDP, so we need to think a little bit deeper in order to decide to reimburse something like this or to negotiate with companies on the cost of the program. And other studies shows that maybe the cost is high, but there is an impact in terms of inequalities in access to such a program and treatment given later on. So ongoing research now focuses on clinical utility and cost effectiveness. And we need to answer both questions. Okay, what about Greece? I would like to remind the audience that Greece is experiencing a severe demographic crisis. We described this as a demographic bomb. Okay? I will share with you the data. In 2023, Greece recorded half the annual average of births in comparison to 4 decades before. And it's high. We closed 700 schools in 1 year. All right? This is serious. Another challenge is our culture on prevention. Okay, prevention was not a priority for health policy for many years. Maybe we could not afford the cost of it. Maybe we had other priorities to cover basic needs. But We've done a lot over the last 4 years. We have the general screening program, Prolambano, that was awarded by the WHO and the United Nations. It's very important. We have more than 5 million people taking part in the program. And we spend more. That, you see now, we spend 3.1 of our total spending. We invest, that's the term. The term invest is better than the term spend. We invest 3.1 of our total spending on prevention, which is similar to the OECD average. While a couple of years ago, we were spending only 1.3. That's a progress, and we keep on investing more money on prevention. And I think that that's why the timing of this meeting is really the right one. And it's a cultural change, because 1 to 5 used to visit a physician with no symptoms back in 2019. Now it's getting higher due to the Prolambano approach of a screening program. And of course, the main challenge remains the economy of the system, the economic situation of the country, which is getting better, of course. And you can see here that we increased public spending by 7.6, but we also increased the private spending by 10.6. And the main challenge for this country is that there's a high burden, financial burden for households. We spend almost 40% of our total spending privately and 33% out of pocket, which means that there's no room for additional spending for healthcare, which means that the burden of such a program should be covered by the state. Manolis mentioned before that there are limited financial tools, but I think that we need to highlight and we need to prove, based on evidence, that it's an investment. So we just need to find the budget to run a program at the 0 point, and this program will save you money long term. In any case, for a country like Greece, but not only for a country like Greece, we need to analyze endorsement, patient preference, and cost effectiveness. We need to move from the traditional health policy approach to an evidence-based health policy approach. We've heard about evidence-based medicine many years ago. Now it's time for evidence-based health policy. So we need to analyze these 3: endorsement, patient preference, and cost effectiveness, in order to be able to answer who pays, I guess the state, at what price, this is negotiable, and for what conditions. In any case, and summing up, I think that the question now is not if we will establish or introduce a program, a GNS program, but how and how soon. Thank you very much.
So that's very exciting, and I'm glad that the quality for expanded newborn testing seems to be accessible even here in Greece. In the United States, preventive screening testing is actually not part of federal funding. Medicare and Medicaid are prohibited actually from paying for screening tests, and it requires special legislation for each test. And there's just actually, in the last bill that was signed by President Trump, there was some funding for this multi-cancer early detection screening, but it required a special law. But of course, screening and prevention are one of the major benefits, it seems to me, to be suggested by expanded newborn testing. Do we have the tools to measure rapidly enough the economic benefit of instituting preventive protocols? In other words, sometimes these prevention will take years or decades to manifest the benefit. You won't develop a disease when you're 50 or 60 or 70 because you were identified as a pediatric patient or a teenager. Do we have the intermediate economic endpoints to be able to do those kinds of determinations?
Methodologically, yes, we could do it by modeling some critical elements, but of course we prefer real-world data.
Yeah.
Okay. And another question is if you are taking into account indirect cost or productivity loss, or just you will compare direct healthcare cost. The second option is not the right one, but this is the one government prefer in order to prove that, okay, this strategy is very expensive, let's negotiate, we need to cut the cost a lot.
Right.
And I want to be fair, we have a very easy access to diagnostic tests in this country. What we hadn't was a strategy, a screening strategy. You can have an MRI in Greece in 1 hour by paying only 15%, and the level of prices are back 20 years ago. So we have very, very low price, testing strategy. We try to contain the cost by keeping prices low, but that doesn't work because volumes are really high. We are in one of the first top position in the world in the ratio of MRIs and CT scans per population. We have more than 4,000 labs in this country. Can you imagine this? 4,000 labs, I repeat. And okay, access is very easy, but at the same time, in some areas of healthcare, we have barriers in terms of waiting time, distance, or cost. That's why 27% of the population say that there is a financial barrier, and that's why we have high unmet medical need. But we need to define what we mean by unmet medical need. We cannot wait. We hate waiting. We seek for direct access all over the country. We have free access to every hospital of the country. There are no catchment areas or reference areas. So we have free access, very easy movement, but of course there are some barriers. Yes, of course we can analyze this. We can model cost effectiveness. Of course there are several hypotheses, but you know that real world data analyses are solid and
to the point of real-world data, it was mentioned earlier that Stephen Kingsmore has done an important study in the newborn ICU at Rady Children's Hospital in San Diego, where he showed that doing whole genome studies on kids in the ICU led to better care, more appropriate triage, more targeted therapy when possible, but also discharges from the newborn intensive care unit sooner for kids who weren't going to benefit from that level of care. And it was, of course, important that it was $100,000 a day for the price for newborn care in the ICU. So economics always plays a role. I'd like to open the panel up if there are any questions from the audience, or, by the way, if you all have questions for each other, we'd welcome that, but I'm particularly interested in if there are questions from the audience or complaints about what we said or not said, please offer them now. And you can raise your hand. We have a microphone even for you. Yes, right here. Thank you for being adventuresome.
No, this was extremely stimulating, I have to say. So I have a question for our policy experts, also the previous speaker, and it is two-part, and actually it's touching a little bit what you were trying to stress before. So best attainable care. What does this mean for Greece today? You went a little bit down the cost effectiveness, the care pathways, but how soon you see implementing something like this, especially when we go out of the existing newborn screening pathways or the conditions that we have today to what whole genome sequencing can do. And the second is the reconciliation between the best attainable care today and the right to a bright future that is related with the secondary findings that someone can have in the second genome, as you said, cancer, risk assessment, and so on. Should those be considered part of the initial model of better care and prevention?
Go ahead. I could say a few words. First of all, we need to prove that it works, and with a budget impact that we can afford. Unfortunately, this is the current view of such thing. Okay, cost effectiveness long-term is very critical. It's easy to, when we have a health technology assessment committee, they will evaluate the whole thing. They will say, okay, it's cost effective, but then there's another one, the negotiation committee, and this one, the second one, will negotiate the cost, in order to, to make the budget impact affordable. That's, yes, it's possible. It depends on the data. And the budget impact analysis, of course. Because it's a matter of priority. You need to take money from another initiative or another part of the system to invest it there.
Barta, did you want to say something about this?
I want to answer her second part of her question. Yeah.
Go ahead.
There, unfortunately, is not. Wait, start positively. While I would propose that there's the right of the asymptomatic at-risk child to be found if it's scientifically, medically possible, that we owe it as citizens to help other citizens, including newborns. Now, in the literature, you see right to an open future. There is no such right. It came in a 1992 article written by a psychologist, and it's coming up more and more because with genetics, the more we can know how open is your future if everything is sort of mapped out. But there is no right not to know either. Now, adults can exercise that right. If I can say, I'm not going to the doctor, I don't want to know. Okay, I'll give my blood because I want to be a citizen, but don't give me the results. So there's a right not to know for adults. There's no right to an open future, and unfortunately, no right to a bright future either.
Yeah, there's a long tradition in the U.S. about the right to be let alone, and that link to the right not to know. Maybe we asked David, are these the secondary findings, these things that may occur, or I know the Genome England has been focused on acute diseases of childhood, of course, biggest bang for the buck, but has there been lots of interest in secondary findings and in later prevention and studying these things as well? Have you noticed that?
So there's a couple of things about secondary findings. In the study that we're doing, this generation study, which is looking at 100,000 newborns, we've specifically put that aside because we were very focused on creating a program where the largest number of people, moms and dads in the population, would say something like, oh, I think that's something I'd like to take advantage of. Because once you start moving out of these highly penetrant, treatable childhood, first 5 year of life onset conditions, as soon as you start moving out of that group, then you start losing enthusiasm from families. So that was kind of, we tried to make this very, very narrow so that we could get the biggest uptake.
Yeah.
The secondary, so we're not doing secondary findings here. With the 100,000 genome project that you alluded to, the project that started in 2012 or 2013 and ran to 2018, they did do a secondary or incidental finding part to that project. And that, I believe, was well received. There is now, and I think I had alluded to this pharmacogenetics effort in adults. As part of that effort, there's also a consideration of what you might call incidental findings, but which are, if you will, individuals who have BRCA mutations, but who just don't know it. And so you could call that an incidental finding. But if you're going to try and pursue genome as a way to help adult populations, you do need to do this consideration of both the pharmacogenetics, which is in some ways the low-hanging fruit, because essentially everybody has a pharmacogenetic variant which will affect one drug or another. But then how do you potentially deliver rarer but important conditions like BRCA? And so that's something which is under active discussion, investigation, work in the next few years, for which we have funding.
Thank you. So I want to thank I'm sorry, we're at the end of our time, but save your question. I'm sure we'd be happy to hear it privately. I want to thank my fellow panel members. I keep calling them family members. Maybe I feel that way about them. But in any event, my fellow panel members, both remotely and locally, for their participation. I think there's lots of reasons to be optimistic about the application of genomic newborn screening and its impact. I think it is fostering an important transition into more precise, more measurable, more genomically informed medical care, and I think that layered on symptomatic medical care and expert-driven medical care is going to lead to better outcomes for people. I think we've heard the necessity for support for research and for the public health sector, and how important gathering data and supporting that, the research in these areas is. And finally, I think we're entering an age where novel therapies for rare diseases, but also for novel approaches for preventing illnesses in childhood or in adulthood is going to become a major effort by society as a whole and by individuals. I think prevention is something that some individuals really warm up to, others don't, but it's going to be possible in ways that never were before. So thank you very much for your attention, and thank you again to the panel.